Thank you very much. I'll take the speaker's liberty of saying that I've had the privilege to work with some terrific genetic counselors over the years, and I have to say I like the term educator because they spend a lot of time, in fact most of their time, educating patients and families, and then me. Well, glad to have some experts up here to help me with my case. So this is actually going to be pretty quick. I was told I had 5 minutes, so we'll keep it very focused. We have a recent interest in some concerns about the association between eating disorders and sudden death. So we were actually going through some testing on unfortunate individuals who suffer from eating disorders, and then when you do that kind of testing, you need controls. So this is the story of a control, not of an eating disorder patient. So I need help with what to do, and I'll walk you through it. So this is my disclosure slide. The only thing that's important on here, I think, is, in fact, that I give away my slides. I'm an open access person. So if you want to take photos and write notes, you're welcome to. But if at the end I will give you my email address, just email me and I will send you my slides. Yesterday I did 2 talks and must have given 50 copies out overnight. So they're all yours. Okay, 16-year-old girl. She and her sister and her parents are altruistic volunteer research participants. There's nothing in it for them other than that this is one of their ways of contributing to science. She is a very fit, active young woman who's perfectly healthy. No medical illnesses of importance, has a family physician. And her mother has some affiliation with our children's hospital, which then gets her into a poster that says looking for research volunteers. And here she is, and this is her resting ECG. So we don't screen the ECG as part of the volunteer process, but we were literally looking for adolescent females to compare to our eating disorder patients. So this is her resting ECG. So I won't belabor this so much, but I might stop and ask the panel, does anybody have a comment or question about the resting ECG in a young, healthy, athletic young woman?
Well, I mean, there are 2 things that you can focus on. There's one, V1's a little bit abnormal with that R prime pattern, but it doesn't seem terribly wide. And then you have that funny T wave in V3 with sort of this bifid T wave. Yeah, you have a T wave in V3 that's a sort of bifid that's a little bit odd, but I wouldn't make much of this EKG if I was looking at it.
Anyone else? I mean, she's got nice early repolarization. Anybody think that V1, V2 is abnormal?
Looks normal for a 16-year-old.
Yeah. So there is a tiny bit of a divide about the adolescent era and the transition of repolarization. She's got a very vertical heart, which is typical of the adolescent heart. So I would have called this very normal. I wouldn't have been worried. And of course, your pre-test index of suspicion is high because I'm standing up here. But anyway, so let's see what happens. So, okay, let's do this. So she stands up. Gets a nice little sinus tachycardia, and then she does this. So, I don't know, guys, am I supposed to grill you, or are you supposed to grill me, or am I supposed to sort of comment and then we run the course of this?
Certainly the T waves become more abnormal, not only in terms of prolonging the QT interval, but also am I close enough to the microphone? Also, the pattern of the T wave changes, becoming inverted out through V4 and becoming increasingly abnormal in the early repolarization phase in the limb lengths.
Yeah, so just maybe to paraphrase that, I'd like to quote Peter Schwartz, who says, I don't measure the QT, I look at the QT. And one of the take-home messages is that if you're thinking about the QT interval, look at the morphology and the duration and not one or the other. So I think most people would say the QT looks long. On a single isolated ECG, you don't want to get too over-interpretive. But the other thing is the morphology looks odd. There is adolescent T waves. There are changes. Girls probably more likely to get some degree of that at certain stages. But I think most of us would agree this is suspicious.
Well, the other thing which is odd is her heart rate, increasing to 130 standing up. So whether she has some dysautonomia or POTS or something is another issue, but that's certainly not normal to have a heart rate go up to 130 when you stand up.
Yeah, and you can see the acceleration over the course of acquiring this ECG, right? On the left-hand side, it sort of looks sort of normal, and then she's going pretty quick at the end. And then, so she just sort of stands there for a little bit longer and then does an exercise test. So this is her peak exercise. So she proved her fitness to us, got her heart rate up to 190. The technologists were wondering if the stress machine was going to break, and is completely asymptomatic and feeling well and asking what's next. And we decided that not much more was going to be accomplished by continuing. And then this is an early recovery, 1-minute recovery ECG. Comments? What do you think of the QT now? Are repolarization changes? T-wave morphology? August panel?
Without measuring the QT, it looks like it's becoming less prolonged, and the T waves look more normal than during exercise, although the T is inverted in AVL.
Yeah, so, I mean, it's quite a bit better, isn't it? That kind of worrisome start got better over time. And we know that recovery is a good time to look at T waves. So, we're starting to feel a little bit more reassured that it was sort of a little bit in the acceleration phase. And this is later in recovery. This is 4 minutes into recovery. And this is actually, she does slow down a little further. For the pediatric people here, there's nice evidence that looking later in recovery is important in kids because it takes longer for them to become a little vagal and slow down. But her corrected QT intervals that I measured throughout most of recovery were about 480. Are we worried about that? Have we accidentally discovered long QT syndrome? What would you say to a volunteer research subject in this circumstance?
Andrew, is there any family history? Have you spoken to the parents?
Very good question. Okay, so patient's asymptomatic. And I was going to present this next, but anyway, patient's asymptomatic, and there is no family history of events of concern. For people who don't work in this space very much, that includes questions about things like drownings, unexplained accidents, so-called heart attacks at later stages in life that are attributed to myocardial infarction without autopsy and so on. And there is none of that. The other thing to me that was compelling is she has a sibling who's a year older, who's also a healthy, active young woman, and her exercise test was clean, plumb, absolutely slam dunk normal. Very different than this.
And the parents' EKG?
Yeah,
the parents' EKG?
Parents had an exercise test, and theirs was also relatively unremarkable. Mom's was a little suspicious, I would say, but not to this degree. And that, of course, came afterwards around the evaluation of first-degree relatives.
Well, but you did genetic testing on her before the evaluation of the other relative, the clinical evaluation of the other relative?
What would you suggest?
Is that what you... So you did first genetics on her and then the evaluation of the first degree, or vice versa?
Well, so this is a health system question, right? So you have a research volunteer with an unofficial exercise test that's on file for research purposes. Are we now going to do clinical genetic testing? Are we going to try to put this in context by doing clinical testing on her parents or research testing on her parents? I'm not saying I have the answer. I'm just saying, I think that in different health systems we approach this differently. And to me it was a particular wrinkle because she's a research volunteer.
Yeah, I would probably have her be well hydrated, healthy, and come back and repeat the test after she's drinking sufficient fluids that she doesn't have the sinus tachycardia response that you saw here.
Okay. Any other?
We will probably have a similar attitude. If there is a suspicion incidental, let's call it as it is in your case, you are allowed to talk to this person and say that it's like when we get picked a regular EKG for surgery evaluation, the anesthesiologist, then we just try to talk to the patient and have them seeing in the clinic to have a further evaluation which gets out of the incidental.
So we go past the incidental either for research or perioperative or something like that, and we're now going to do a clinical exercise test to look for reproducibility.
Right. Your pretest probability, other than you standing up here, is that it's a false positive, much more likely than a true positive, just based on her lack of history.
So I'm not sure we said anything specific about hydration, but we did talk about all that healthy living aspect of things, repeated the test, and it wasn't meaningfully different. It was maybe a little less striking, but it was certainly struck us as concerning. So we now have a clinical test on file saying she has, she has QT prolongation and appears to have findings that are concerning for long QT syndrome. Okay. I am not trying to trick you. I am trying to get you to the dilemma. Okay. So we did genetic testing on her. And her genetic testing, I have this hobby of trying to predict the results of genetic testing, and her QT changes, including shortening and early recovery, are very consistent with that morphology of type 2 long QT syndrome. And in fact, she came back with a variant of unknown significance in the LQT2 gene, which sort of fits with the idea of the clinical phenotype. Quite conceivable that she would be asymptomatic because her QTs, although they're a little bit concerning, are not compellingly long. And of course, mutations can either be relatively silent in the family from a clinical events perspective or novel. So now what? Chris looks like he wants to say something wise.
The variant of unknown significance, can you elaborate a little more about the evaluation of the variant? I mean, aside of just this,
Okay, so I got this yesterday, so no.
Okay, so that will be what I will do first.
Yeah, no, so first of all, for people who don't do this very often, there is a fair bit of due diligence that happens before you get a report like this by a group of people who are typically PhDs working in the labs of these commercial labs. There's some recent evidence to suggest that process is not highly standardized, so the same genetic information, if you like, coming from one lab or the other may be classified differently. This is one of the reasons for advocating that there's an overread of this also by the local team, which involves that multidisciplinary team. So our version, or interdisciplinary team, our version of this also involves a network of some basic science people who have both genetic and expression kind of expertise. And it's unrealistic, of course, to expect that your patients are going to get somebody to do a cellular expression model of their genetic findings. But asking somebody about this who spends a lot of their time thinking in this area can be very helpful to say, I think this variant is likely damaging, is likely a benign variant as a gene modifier, but it's probably not that important. I think it's improbable that a single individual is going to be able to hold all that in their brain, and that's the reason for the need for collaboration or the benefits of collaboration. So maybe one of the take-home messages is these kinds of things are a start, and they also need to be revisited. So, for instance, if we were able to test 15 family members and had a rigorous evaluation of phenotype and genotype, we may reclassify this finding as being more likely to be disease-causing or not. So, again, that part of our exercise is to now chase this, even though it lands on our lap accidentally. Okay.
I'm just curious, I know you just got this yesterday, but in terms of what the genetic testing laboratory did provide you, was it novel? Was there case data? Is it sufficiently rare? What part of case NH2 is it in?
Yeah, it's novel. I should have generated more of this on the report. I apologize for that. It is novel. So it's not been reported before. We haven't, obviously, because it's literally hot off the press, we haven't evaluated this in other family members.
Did you have an idea of how many controls internally this lab has to check this? So each one of the lab have
the audience sounds like somebody who really wants to make a comment.
Can you come to the microphone?
I think you said that it's been
Will you come to the
described once by
microphone,
the Royal
please?
Brompton team.
It's been described with one patient with long QT.
Okay. So
Single
again,
patient.
the degree of due diligence on my part is incomplete. The point of it actually was not to focus on the details of the genetics as much as they are highly relevant. The point of this is to try to actually, okay, I'll get on with my question. My question is, she's got a U.S. scholarship to go to play field hockey. She's a national level athlete. And my question is, what the heck do I do now? Does this influence her safety to play sport? Do I inform the clinical authorities? What does the coach and the national field hockey team need to know? Will NCAA Division I field hockey eliminate her eligibility to play sport? Shall we destroy her life because she's a research volunteer who has incidental detection of asymptomatic QT prolongation?
Well, you made an interesting point right at the very beginning of your talk, and you hint at it, or you directly address it here in this slide as well, is that you have a family who's very cooperative and very interested in being helpful for you. And so as you finish teasing out the best information we can provide as a field on this particular variant, fortunately you have other exercise stress tests and other experiences in the family that I agree with your comment that I would test the rest of this family for variant of unknown significance and map it to where the phenotype exists in the family.
And I don't think that at this stage, I'm not sure, admittedly, just alone because of the variant of unknown significance, you are pulling her out for her scholarship or so immediately. I mean, this is more like what the European conundrum will be, because in Europe you will be out right away. But here there is a much more flexibility in tailoring the evaluation and concluding first. I mean, at this point you don't even know if she really has LQT2.
Although that EKG was clearly strikingly abnormal. So I think you can look at it the other way and say this incidental test potentially saved her life, and I don't think she should be doing competitive athletics. I mean, she can, that EKG is so abnormal, as far as I'm concerned, she shouldn't be doing competitive athletics anymore. But I'm not the expert on LQT.
So what we would do, I mean, I can only comment on my part of the interdisciplinary team, but I would turn to my cardiologist colleague and say, what do you think of that EKG? And if he said to me that is truly, truly abnormal, and we have it repeated now, a second measurement that is abnormal, I would say, well, here's what I know about the genetics, and this is definitely inconclusive. We don't know if it's the cause of her EKG abnormalities. We shouldn't be testing the family for it because it can't tell us anything about their risk. But if we do have other family members who show a prolonged QT interval, let's test them for the variant to see if it tracks. And if you tell me the EKG is truly abnormal, regardless of the inconclusive genetic test result, because that's uninformative, then the first-degree relatives of this girl need to be getting EKGs, stand-up EKGs, and exercise tests on a serial basis, because even though they've had normal EKGs to date, they may have concealed long QT that could come out on another evaluation.
So I agree. There's three options here. She's got gene-positive long QT, which she doesn't have. She has gene-indeterminate long QT, or she has gene-negative long QT. But all of them end with the word long QT. She has long QT. That's it. So I think the genetic information is very helpful and potentially useful, and we need to do clarification and segregation. For the audience's sake, there are some questions about the merits of chasing a variant of unknown significance, which we often don't advocate chasing in families because it's an indeterminate test. But I think she has long QT syndrome.
Well, but then following up, I'm actually feeling that I agree more with Hugh. You're saying, I'm destroying the life of this girl, maybe you're saving it. And also, how destroying is to start beta blocker in a young person. Beta blockers are fairly, quote-unquote, innocent drugs that may protect her. So even if then you, in following up, decide to pull it out, you're not damaging her much.
I think the hard thing, too, is, I mean, there's so many things about this case, Andrew, that are so tricky, because you're also touching on what is a moving target in a huge debate, which is what should we be doing about exercise for long QT patients, especially a possible type 2.
That's the choice of case. Yeah. Absolutely. So, I suppose, I don't know, are we out of time? Are we getting out of time?
We should wrap up and move on to the next two cases.
So my take on this is that there is a reasonable probability of detecting incidental QT prolongation when people undergo varying things, including perioperative, a bunch of different reasons. So the notion that most long QT shows up with somebody fainting or dying and then having long QT is not necessarily the case. So you need to be prepared for incidental detection. So second thing is, conventional risk parameters in somebody like this would suggest she's very low risk, right? Arrested QT is not terribly long. If she's female, she may or may not have type 2 long QT syndrome, so those are more risk. And the absence of being symptomatic, so there's a bunch of reasons why you might argue that she's at low risk, particularly if she's beta blocked. So there's even some biologic reason to believe that type 2 is actually at high heart rates when she wants to be competitive, or in fact have shorter QTs, much more so than ones. So it's quite complicated. The problem is in the regulatory environment, just give me a second if I may. In the regulatory environment, the eligibility for sport is highly variable depending on context and so on. And so the effort to establish a relationship with the people who are decision makers in this is very important. Because you want to advocate for both the safety but also the quality of life of the individual who's involved. And it's complicated. Yes, question in the audience.
Can you come up to the microphone? And also, we want to know, Andrew, not going to get off the hook without telling us what you did for this girl before you leave.
Sure.
Yeah, I'm just looking at the guidelines, and I'm not seeing why you're saying this has long QT. I didn't see how it met the guideline definition of having long QT.
So there's a bunch of work that looks at the extent of QT prolongation, including with exercise and recovery. One of the Schwartz score points is recovery QT prolongation to a certain degree. It's a phenotype recognition more so than the diagnostic guidelines. Her Schwartz score would give her an intermediate diagnosis, but quite frankly, I think that's an abnormal exercise test for sure. And of course, I'm going to be wrong once in a while, but I think I'm prepared to make that comment. Oh, Professor Viskin.
I think the other thing, just to add to that, is while the genetic testing is inconclusive and we can't use it to assess risk in her sister, it can still factor into your diagnostic evaluation. And while that's not in the Schwartz score, the fact that she has a rare KCNH2 variant and conditions the probability up that she actually truly has long QT, right?
Right. And we will, obviously, we're going to complete both clinical and genotypic, if you like, segregation analysis as extensively as we can to try to provide some guidance around this. Sam?
I would argue that we should go back to her baseline ECG that was strictly normal. She doesn't have a long QT. She has a normal QT at rest.
Yes.
She has abnormal testing, which is a completely different story. We defined what test is normal or abnormal based on a very limited number of individuals. And in our own testing of the quick standing, we had a 10% false positive rate. So she has a normal QT. She doesn't have long QT syndrome. She has an abnormal test. We do not really know what to do with this abnormal test. We should not be calling her a long QT. And in our experience, when you have a false positive to the quick standing, you also have a false positive response to the exercise test, which means that there's something abnormal in your response, but that does not make you a diseased person with a long QT. The maximum I would do to her is would advise her to be careful with medications that prolong the long QT, not more than that.
Avoid QT prolonging drugs.
Yes.
So you wouldn't beta blocker?
No.
Okay.
Yeah, I was going to make that point too. How do you know that they're not true positives that are asymptomatic and have never had an event?
Well,
I agree with you, by the way. I'm just sort of playing devil's advocate.
Because if you invite a guy from the audience to serve as a control, and they have a positive response, you have to call this a false positive. And obviously, you're going to miss a few sick individuals there, but 10% is far more than the prevalence of the long QT syndrome in the population.
Yes. Okay, so Andrew, so what did you do?
So I beta blocker. Low dose bisoprolol, long acting, generally well tolerated, not particularly potent, but that's part of its tolerance. One of the other people involved wanted to put her on Nadolol. I think that would be actually a reasonable and probably more protective thing. We told her that the evidence to do this is entirely judgment-related, not because she has a compelling case, and said we would complete our genetic evaluation and clinical evaluation of the family to try to assign some pathogenicity to this.
All right, let's do a quick audience response. We don't have to use your phones. We can just do a show of hands. Unless, is that...
By all means, okay. So let's do it this way. Who thinks that she has long QT syndrome? You're going to get to vote yes or no. Yes. Who says no? Okay, so that's what, 60-40 for no? Okay.
Least, yeah.
Who would put her on a beta blocker? Who would not? That's 70-30? Okay, okay. So
restriction.
Who would defend me if we don't do anything and she drops dead? Okay, okay, thanks. Well,
who would restrict her from
address, please?
Who would restrict her from competitive field hockey? A few. So most of the ones that think that she has long QT still wouldn't restrict her.
Yeah. So for instance, that's one thing I didn't comment on. So I would not restrict her, and I did not restrict her. And one of the reasons to beta blocker was actually so that she could be as active as she wanted to be. In fact, that was the partnership. The partnership was, I think that you're probably fine that you're at very low risk. I think if you want to be as active as you want to be, in principle, I feel you'd be safer on a beta blocker, and that was the action. So they were sort of linked. The wrinkle is, at least somebody can please correct me, NCAA Division I will exclude you from participation if you're diagnosed with long QT syndrome, exclude you. So I've got several NCAA Division I athletes who are Canadians now competing in Canada on a waiver instead of competing in the U.S. because they were disqualified in the U.S.
So did you consider how you documented her phenotype in your note if the exclusion criteria is diagnosis of?
I mean, put it this way. I try to carefully craft the language around what you call it. So in principle, the term syndrome is different than an abnormal test. I think Sammy makes a very good point that way in terms of the language. We do have a bit of a zero-tolerance environment amongst a lot of the regulators and so on, so sometimes nothing you say will get – because you can go to bat, write a letter. I do this all the time. That, this kid should not be restricted from going to camp, from playing recreational hockey, whatever those activities are. And people are still unreasonable, is the polite way to put it.
Thanks very much. Let's move on. Thanks very much,
you.
Dr. Krahn.